Hey everyone, I just wanted to do a quick wrap up of what we talked about, what we covered stress, crisis, and anxiety. I know it's been a very busy few weeks with exams, so hopefully this is helpful to those who need that little refresher. So, perfect timing as we finish up exam one stress. Everyone has stress, it is so common in our everyday life, and stress isn't bad. Severe stress is when it becomes unhealthy. We watched a few videos in class. We talked about it. When we are stressed, when we have that anxiety, that cortisol is releasing, and that cortisol weakens our immune system. It makes us more susceptible to diseases. So, in an individual who has severe stress, where they're chronically stressed, they're more likely to be ill. Our job as nurses, as we talk about stress, crisis, and anxiety, kind of all ties together. We need to understand what is going on in our patients and identify how we can intervene. How can we reduce their stress? So, having a calming environment. If we have someone who's coming in and having a baby, that is an extremely stressful experience. And if we have a more calming labor and delivery type unit, that can promote healing and calming in that patient. Coping. What are the mechanisms our patients are using for coping? Do they have coping mechanisms? Are they adaptive or maladaptive? And then taking a look at what those mechanisms are, and especially if they're maladaptive or if they don't have any coping mechanisms, and looking at what we can do in the future. So we have a few stress response theories. Fight or flight is one of the biggest. It's how we prepare with a threat. And generally we tend to think about fight or flight like that lion. If we have a lion who is coming after us, what do? Are we going to fight the lion or are we going to run away? General adaptation syndrome is a little bit different. There are 3 stages. In the first stage, alarm, it is when our body is like, oh my gosh, hey, something is happening. It is initial, brief, and generally adaptive. The alarm is generally that start of that fight or flight. And it's sending our information to our brain. It's getting that hypothalamus involved. It's signaling our sympathetic nervous system. And in that alarm stage and or fight or flight, right, heart rate is increasing, blood pressure is increasing, breathing is increasing to send more oxygen to the brain. Our pupils dilate. We have a larger perceptual field. Glucose is increasing, right? Our body is dumping glucose into our bloodstream to give us extra energy. Blood goes away from your digestive tract to look at our more important urges. As that initial kind of stage subsides, as we go through that fight or flight, if the threat continues, we go into what is called resistance. Our body is now tired. We have used all of our glucose. We have used that extra energy, and we are now trying to resist that stressor. It is a hard phase and very hard on the body. We have used up our resources, our adaptive energy, and if that stressor is continuing, if we go through that resistance stage, we basically go to exhaustion. We cannot resist the stressor, right? In the alarm stage, we see the lion and we get that extra energy to take off running. But I can only run for so long. And eventually, if I cannot outrun this lion, I become exhausted. I don't have a choice now but to face the lion head on. And that long-term overexposure to cortisol leads us more vulnerable to illnesses. Bad versus good stress. It's also called eustress is good stress and distress is bad stress. Just because something is positive, having a baby, getting married, winning the lottery, doesn't mean that it is not stressful. So both things that are positive and things that are negative still have effect on us and on our body. So with all that being said, different types of stressors. Physiological. You are stuck outside, air conditioner's broken, and it's 120 degrees. Right? Or same thing, Texas. We have a snowstorm and you lose electricity and it's really, really cold. Psychological stressors are the ones we tend to think about. We get fired, we have a test coming up, we're fighting with a loved one. Perception is a big thing that helps determine how we view that stressor. If you have had a situation before, if you have coping skills, you have that family support and background, it's not going to be as stressful. In class, we talked about I grew up in an area where we had lots of hurricanes. So for me, I'm like, hurricanes, got it, I can deal with this. If we had someone who had never been in a hurricane, never had to evacuate to a hurricane shelter, they're going to view it differently. All of the different things, age, culture, history, lifestyle. I know my kids are like, wait, We don't have internet. There's no electricity. Like, why can't you get the internet to work? Because for them, electricity and internet are all of the things. Some of us didn't grow up with internet everywhere, so we're like, nah, we'll be fine for a little bit. Temperament is a lot of just that who we are. Um, and honestly, temperament is kind of a combination of everything: genetic vulnerability, childhood experiences, coping strategies, outlook that form just us. Some people are going to have that more anxious temperament where they're kind of like those negative Nancy's. They're going to look at the situation and think that it is negative because that is shaping their outlook. Social supports, who do you have to turn to? Do you have a loved one, a family member, a friend who you can be like, in that moment, I'm going to turn to you and it will all be okay? Or do you have no one? And that kind of goes with support groups. Do you have a specific support group? Do you have, friends outside your family? Do you have medical providers, therapists, social workers, AA, if we're talking about, right? Those who are struggling with addiction. Who else do you have? Culture, all of our cultures are going to emphasize certain problems of living more than others, but they also help us interpret our emotional problems differently. Spirituality and religion often help us cope with stress. Most religions tend to promote hope and optimism, and it helps give us a positive viewpoint. So we talked in class about our different stress busters, what are we doing, and some of the positive, the adaptive things we do for ourselves, we can teach our patients. We'll look at some examples coming up. We did a recent life changes questionnaire where it looks at, hey, given what is going on in our life, how are we handling stress? Again, when we did this, we have to remember all of us are going to perceive events differently. So we all might check off something as happening in the last 6 to 12 months in our life as stressful. However, we're all going to view it differently, and we're all going to handle that stress threshold differently. So we have generally 4 categories of coping mechanisms: health-sustaining habits, medical compliance, proper diet, relaxation, life satisfaction, work, families, hobbies, humor, spirituality, arts, nature. Social supports, who are we talking to? And then overall, our effective and healthy responses to stress. Are we using like relaxation techniques, deep breathing, progressive muscle relaxation? And each one of these can go from healthy, adaptive, or unhealthy, maladaptive. So like diet under a health-sustaining habit. Are we eating a well-rounded diet, or when we get stressed, do we not eat? Or overeating, do that carb loading? I know I tend to go to give me all of the sweets. Hobbies. When we're stressed, do we keep up with our hobby or do we turn away from it? It's really important to look at our patients because oftentimes meds are going to help, but we have to have those coping strategies too. We have to have those in place. So this is kind of a sheet. I've added this in. I know y'all don't have it. I've used with my patients before, more so some of our peds patients, and it just lists what are some coping skills, because we can give our patients a handout and maybe they didn't think about it, right? Go on a hike, use compassion, journal, cook, ride a bike, cry, that catharsis, positive affirmations. We tend to list some coping skills, but we don't always get that many. So by having a reference for our patients, we can see what some more of them are. We also have relaxation techniques. Biofeedback is wonderful, but it's hard to do because we need equipment. We are looking at our body changes. So we're going to look at your heart rate and your breathing and your perspiration when you're anxious. And then as we walk through coping mechanisms, we can see our heart rate reducing. We can see our blood pressure lowering. Not many people do biofeedback. If you have a smartwatch, it's available there. So I kind of wish we did it more. Deep breathing exercises tend to be the most common because they're so easy to do. Inhale, hold, exhale. And we did some exercises in class. There are more that we can do. Guided imagery, close your eyes, think about the beach, feel the water and the sun and the cold drink in your hand. A lot of good research and guided imagery and pain management, especially labor and delivery, and how we can use that to calm our patients. We did some progressive muscle relaxation in class. That is often that kind of like stretching, tightening of our muscles throughout our body. And it's almost like this, like you get nice and tight and then you release. And over time, we have now physically released our whole body. When we're stressed, we tend to carry that tension in our muscles. So by using progressive muscle relaxation, we can let go of that tension. And then meditation, it kind of goes along with some of these, thinking about the positives, going through, maybe we have like a mantra. We did some progressive. So again, stress reducing techniques, some other examples, physical exercise. Physical exercise is great. It's a preventative. We want our patients to walk 20 to 30 minutes a day, right? Does not have to be doing CrossFit, any type of activity consistently more days than not. Kind of sets our body up for a good place to prevent stress. Cognitive reframing, that is when we take that negative thought and change it to a positive. I love the word yet. I'm not good at this. I'm not good at this yet. With practice, I will get better. Journaling, humor, calming music, pet for social support, practicing that deep breathing, so many different stress relieving techniques. So we're going to switch gears now to crisis and disaster. So when we have someone and there is stress and anxiety and it continues, or when we have a specific event that is not one that is expected, we can have a crisis. Crisis can be individual, group, or society. I can lose my job and it affects me. There could be a storm and a tornado takes down my house and my family, my neighborhood is affected. There could be a massive, like September 11th, a terrorist attack where it affected most of the whole of America. So crisis and intervention are those small time-limited things that we are doing to help individuals in a crisis. And the whole point of that crisis intervention is to keep you safe, reduce anxiety, and return you to your pre-crisis level of functioning. Things we're going to look for in a crisis, again, that perception. If we have someone and they're like, hey, listen, I live in Houston, it floods all the time, this is no big deal, right? It still might be stressful, but they have experience and a plan set up. Maybe they have family they can live with and, a good insurance, all sorts of different things. And then what are their coping mechanisms, especially kind of maybe what have you used before? You might have never dealt with a massive flood or a tornado. However, in a different crisis situation, because usually we're going to have a few in our lives. When your mother passed away, what was a coping mechanism you used? Because then it can kind of set the ground of what works for that patient. We had a few different types of crises: maturational, situational, and adventitious. Maturational tends to get linked with Erickson, and it's each developmental stage we're going to have a developmental crisis. As we go through these stages, the coping mechanisms I had before aren't necessarily working. My coping mechanisms in intimacy versus isolation are not always going to work in generativity versus stagnation. In Erickson, how we move and progress affects each other, and we need those new coping mechanisms. Once the crisis is ended, that maturational crisis, growth and development continues from that point of interruption. So we're going along in a stable line, crisis happens, we stop growing and developing, but once we have overcome the crisis, we start right back up where we were and we keep growing. Examples of a maturational crisis: getting married, moving out of your house, getting new jobs, having or losing a job, having to put your parents in a nursing home. We talked about death. It does say death under situational crisis. However, I need you to bear with me on this one. If we have 95-year-old grandma and it's anticipated that grandma will be passing away, because we can see situational is unanticipated. Maturational tend to be anticipated, right? As we grow up, we expect to get married, have children, get jobs, move out of our parents' house, have to deal with our parents as they age, have to deal with grandma and grandpa, have to deal with our kids leaving the house. Those are our maturational crises. Situational crises are unexpected. Divorce, death, death of a child, death of a spouse at a young age, change in financial status. those kind of fall into that situational. They're not crazy, they're not things that we would never expect to happen in life, but we are not anticipating them to happen. Adventitious crises are the ones where you're like, oh my gosh, this is a catastrophe. They're things that usually don't occur. Tornadoes, floods, rape, school shootings. Like we can see, these are the things where you're just like out there. Um, Hurricane Katrina, Hurricane Harvey, the fires in Maui, all of those would fall under adventitious crises. So phases of crisis. The first phase is when the situation happens. Our anxiety increases and we start to use our defense mechanisms. And defense mechanisms are those kind of innate things that we have inside of us. Our denial, our rationalization. Phase 2. My defense mechanisms is not working and my anxiety is increasing. So during phase 2, I trial and error. I'm doing my best just to restore balance. In phase 3, my trial and error did not work, so I wind up in fight or flight. I'm now at that severe anxiety or panic. In phase 4, I'm completely overwhelmed, depression, violence, right, suicide. It is a crisis. We looked at this table kind of from your book where we can see as a human organism, we want equilibrium. Any stressful event is going to cause disequilibrium in our body, and we're going to want to just restore it if our balancing factors are not present. So if I have a distorted perception of the event, if I don't have social support, if I don't have coping mechanisms, my problem will not get resolved. And I will remain in disequilibrium and I will have a crisis. So assessments. We have to look at how the patient is looking at the event. What has brought them in for treatment? What is the precipitating event? How is it affecting them? Who can they turn to? There were a lot of churches over snowpocalypse in 2021 here in Austin who had electricity and were taking in members of their community, right? So that religious group reached out during that crisis situation to provide support to their church members. Families were taking in loved ones. Coping skills. Positive, negative, right? Positive are also adaptive. Negative, we tend to also hear them as maladaptive. So are they seeking treatment? Are they using their deep breathing? Do they have coping skills? Negative, are they drinking? Are they using drugs or overeating or fighting or maxing out credit cards? Self-assessment tends to look at us. It tends to look at how are we affected by our client's crisis. We do have such thing as secondary trauma. When our patients are kind of dumping their problems onto us, it does affect us. So we do need to make sure we are taking a step back, potentially debriefing after those events too. So some of our priorities, and I feel like this is a little backwards, before we start talking about why are you here, or really going into detail about coping skills, we have to assess for suicide and homicide. That is one of our priorities, right? Have you thought about suicide? Have you thought about ending your life? Then we go into coping support system and all that other stuff. We want to keep the client safe, and that goes into if our client is, not feeling suicidal, we want to put them in a safe place. If our client, we're in an outside area after this situation, we want to move them internal. And then we want to, again, look at how they've dealt with this before. As we kind of go through that, how have you dealt with this before? Then we go into support and coping. What is it that we can do, and what is it we can teach you? We have a few levels of care, primary prevention, and we've talked about this before. I want to teach kids. I want to teach those kids coping skills and problem solving so that when a crisis occurs, because let's face it, a crisis will occur at some point, we have a foundation of resilience. Secondary care is what we are doing in that moment. The crisis has happened, and during that crisis, what are we using to stabilize? Tertiary care is the crisis is over, and we want to, because our whole goal was to get you back to that pre-crisis level of functioning. So the crisis is over. What can I do? Can I get you to support groups? Can I keep teaching you coping skills? Set you up with a therapist to get you optimal level of functioning back to where we were pre-crisis. We talked about a bunch of different modalities. I'm not going to go too much over these. they're wonderful to kind of connect to the patient in that moment after that crisis. So now we're going into anxiety and obsessive compulsive type disorders. So anxiety is super basic emotion. We all get anxious. Y'all have a test, you're anxious. You're driving down the road and there's a police behind you, you are anxious. Your significant other looks at you and go, we need to talk. We get that little bit of anxious. And we need that anxiety to survive. Anxiety helps us carry out tasks. If I was not anxious about a class I was taking, I would probably not study. And that minor, tiny, mild anxiety gives us that motivation to work towards our goals and to be constructive. However, we have different levels of anxiety. So that mild anxiety, we can problem solve, right? When we're talking about like maybe physical symptoms, maybe we're drumming our fingers or twiddling our finger, right? Like drumming our fingers on our desks, fidgeting in our chairs. But for the most part, when I look at someone, I don't see anxiety and mild. We can grasp information more effectively at that point. When it becomes a problem is as we start to move towards moderate. Moderate, we tend to get that selective in attention. Our thinking isn't as clear. We're not as great at problem solving. And we start to see that sympathetic nervous system get involved. So increased heart rate, blood pressures, respirations, our stomach gets upset. Our perceptual field starts to narrow, right? So we can't focus on everything on the periphery. Severe anxiety tends to be fight or flight. I'm not noticing the flowers when I'm focused on the lion that is chasing me. So I'm not going to be able to learn as well. I'm not going to be able to problem solve as well. My perceptual field is going to be greatly reduced to the lion. We tend to see a greater increase in physical symptoms, right? That heart rate, blood pressure, respirations, GI upset, headaches, nausea, insomnia. Maybe we're hyperventilating. So severe tends to be that fight or flight. Panic is not, right? That's your panic attack. That is again, so even more than severe, we have panic attack. It is our most intense. This patient has markedly disturbed behavior. They may be running, shouting, screaming, frozen, pacing. We don't always know. They cannot process any information. They are out of touch with reality. They may be impulsive, and their physical behavior may be erratic and show that. So how do we deal with this anxiety? We have some defenses against anxiety, and these are automatic. These are very Freudian, right? Freud is the one who came up. These are things that our unconscious are doing to help protect us, to help ward off the negative feelings. We, again, are not always aware that we're using them. We have some adaptive ones or ones that could be adaptive. Sublimation, we talked in class. We have someone who always wants to fight, and they're getting in trouble at school for fighting. So what do? They join the football team. Sublimation will usually always be healthy because we are channeling negative impulses into a positive. But we do have some maladaptive denial. I don't have a problem. Right? Displacement. My boss yells at me, so now I'm coming home and I'm yelling at my spouse. I can post a link to this video. It's a very quick, brief one on 10 defense mechanisms that kind of goes over it. And then we have our anxiety disorders. So remember, while anxiety is normal, when they continue and when they start affecting our life, that is when we tend to see them become a disorder. So separation anxiety is extremely normal in young children. You drop off your kid at preschool for the first time, we expect them to have some separation anxiety. However, we label it a disorder when it continues. When our 17-year-old cannot separate from us, right? We can't send our 17-year-old to school because they will be having a panic attack. We often have a lot of physical symptoms as well as emotional. So GI, headache are common. And it could be, I think the example I gave in class, we have someone where mom went to the grocery store one day and then mom was in a car accident and never came home. So as a child, that child just learned, well, my mother left and she died. So now that child struggles to separate from dad. We have a whole bunch of other reasons how and why that can occur. So we watched this whole video. Phobias, lots of phobias. Do not try to memorize all of your phobias. You would be there forever. And there are just so many of them. So this is an irrational fear. This is not like, oh, I'm afraid of a spider. This is like you see or think there could even be a spider in the room and you are having a panic attack. This goes to fight or flight, goes to panic. When we have it, it is crippling. You cannot function daily. We are adjusting our life because of this. We have some things we can do for patients with phobias. We can definitely teach coping skills. Hey, listen, very sorry that you're afraid of this. However, but for someone who is afraid of driving, right, I can't always just give you like a medication. We have to confront it head on. Um, Systemic desensitization, that person who's afraid of a spider. So I show them a picture and then a stuffy and then a movie and then a real spider, where we can slowly expose you and then talk about it. If you're afraid of driving, right, I have to give you those coping skills and continually try to work with you. If we have someone, right, dentophobia, fear of the dentist, and they don't really have to go to the dentist that often, we just might find someone who is willing to use a benzo. But that is not necessarily going to be a long-term solution. Benzos for phobias are good band-aids. Social anxiety disorder, you get very scared talking in public. And again, this is not just like very scared, this is severe. I cannot order at Starbucks. I have to order online. I'm going to walk in, I'm going to grab my drink, I'm going to leave. If it is wrong, I will just suck it up because someone might make fun of me. I could say the wrong thing. I'm going to make myself look like an idiot. And we get this like snowballing. If they do have to go and talk in public, it will cause extreme anxiety. They'll go to a restaurant, but they might not order. And sometimes even going to the restaurant, what if I get food stuck in my teeth? What if I knock over my drink? What if this happens? They're going to be thinking of all of those things that could happen while they're out in public. So panic disorders. Panic disorders are random panic attacks. So if you are in a car accident and you're like, and you start hyperventilating, you could have a one-time panic attack following that car accident. But someone with panic disorder is continually having panic attacks, sometimes, right, unpredictable, out of nowhere. And they might just be going about their life without a trigger. You have this sudden onset of feelings of doom that can last for several minutes. They're not going to be able to function, their perceptual field, they're out of touch with reality, chest pain, shortness of breath. And it's hard because when you're not having a panic attack, these patients may be afraid of the fear of that panic attack because it can come out of nowhere. For this patient, we have to be cautious and make sure it is a panic attack. And panic attacks in general. Your patient, maybe they are like, I've never had one, or I've had one, but I haven't been having it for a while, and they're coming into the emergency room complaining of shortness of breath and chest pain. We have to rule out those medical symptoms first. We have to make sure it is not a panic attack. It is not like a stroke. There's nothing else going on medically. And then we can start to address. Panic attacks really have to be preventative, our treatment for them. Teach the coping skills, teach the relaxation, get them on a long-term medication for someone who's having those repeated panic attacks to be able to address them before they even come. We talked about my husband, he has a history of panic disorder where he has these random panic attacks. And that's kind of what we had to do. And we went from having, panic attacks frequently to one every so often. See, he talked about his panic attack. So agoraphobia, this is one of our phobias we are going to talk about, and it goes along with panic attacks and panic disorder. Some individuals with panic disorder, you will sometimes see it labeled panic disorder with or without agoraphobia. There is such anxiety about being in a place where you can't escape, where you can't get help, that these individuals just stay home. They avoid those situations. We often think of agoraphobia as like fear of open places, but it's more about that fear of not being able to get help or escape when out in public. This is debilitating in that the patient will stay home. We watched that little clip and she's like, sometimes I go to the corner, sometimes I go to the backyard, but that is it. We may often have some type of stressful event, and then that makes it better, right? I had the stressful event, staying home makes me feel better. If we have someone who's out in public and there's like a shooting and they could struggle to get away, they might now get into the mindset, home is safe, no one will shoot at us while we're at home. And I know that is a very extreme example. So generalized anxiety disorder is one of our big ones. This person has kind of a moderate anxiety 24/7. Everything causes them to worry. constantly like putting things off, avoiding reassurance. They're not going to be sleeping because when you sleep, you can't turn off your mind, and that little tiny worry snowballs into a I'm going to be homeless and living on the streets and my life is over. Um, we do have physical symptoms, headaches, GI disturbances, tension, muscle tension. Um, and this is someone they're going to think about all the things, you know, 20 years ago in elementary school, this happened and I shouldn't have done this. And oh my gosh, what if I do this in the future? They're just constantly going to be thinking about all of the different things that could happen. Obsessive compulsive disorder. We watched a little bit of a clip from As Good as It Gets with Jack Nicholson. Your definition that we tend to have in society of OCD is not our DSM psychiatric diagnosis. This is not your type A perfectionist. That is OCPD. So OCD is a diagnosis where we have an obsession, right? Intrusive and recurrent thought. And that obsession gets into your head. You don't want it there, but you can't get it out. And that obsession lodges itself, you can see the little chart at the bottom, lodges itself in your head and it causes anxiety. So the example we talked about in class, just because it is so clean cut, the documentary I'd watched once about people with OCD related to driving. So this person gets into their car and they are anxious. And the thought is, oh my gosh, I went over a bump and I hit this bump and I might have hit a person and I might have killed someone. So the obsession is, what if that bump that I just drove over is a person and I have killed someone? Having that thought is going to be anxious. You're not going to be able to focus on anything else. Your anxiety is going to be increasing. Oh my God, I just killed someone with my car. Now, that person is going to develop some type of compulsion, which is a ritual that makes the anxiety decrease. So in this example, you have a bump, the anxiety, obsession, oh my gosh, I killed someone, it spikes our anxiety. So we stop the car, we pull over, we get out, we walk around to make sure we did not hit anyone with our car. So that compulsion, that checking is a ritual. Every single bump this person goes over to, they are going to have to get out of the car. By doing that, it temporarily decreases anxiety and provides relief until we go over the next bump. Anxiety is very much a cause and link in OCD. It causes distress, often humiliation, right? Jack Nicholson was kind of like walking all funny, flipping light switches a few times. These individuals usually recognize that this is not okay behavior. They just can't stop it. There are a whole bunch of different obsessions. We tend to think like germs and hand washing, contamination as a common one, but we do have a lot. So what do we do for this client? We need to get their energy out in a different way. We need to teach them other type of coping skills to calm them. We do have to be cautious. We don't want to give them a new compulsion. That is a concern. So this is our little Jack Nicholson's video. So body dysmorphic disorder. This is not necessarily an eating disorder. This is, hey, there's something in my body that is just not right. My nose, it's not a good nose, right? We can see this person looking in the mirror. What she's seeing in the mirror is not what she is like in real life. So this person hyper focus on these defective body parts, even if it is something silly. Our little video, she's like, but my ears. There's probably nothing wrong with her ears except to her. And there's these feelings of shame, disgust, depression, lots and lots and lots of plastic surgery, high risk of suicide, and struggles in the family because the family's not just going to pay for the plastic surgery. Hoarding disorder is when we generally tend to know a whole lot of reasons why this can happen, but we are accumulating items, all of the things, and there is an anxiety that has to do with parting from it. Is this someone who came from a life where there really wasn't much of anything? And the thought of getting rid of stuff is hard. Some people, the thought of getting stuff is positive, like, right, positive. So they get and get and get, but they can't separate. We tend to see environmental concerns. No one's going to visit. The house is going to become unsanitary. Is it cats or dogs? We got like bugs and fecal matter like in the house sanitation and we don't know. High rates of depression and anxiety in this patient. And most of these patients are not going to be seeking out help because they do not see this as an issue. Trichotillomania and excoriation kind of go into OCD. I have anxiety, so that compulsion to calm my anxiety is pulling out my hair or picking my skin. Um, by doing these actions, it decreases anxiety and stress. Trichotillomania specifically is hair pulling, excoriation is specifically skin picking. So, why does anxiety happen? Genetics. If you got a first degree relative with anxiety, you have a higher risk of developing anxiety. Neurobiologically, GABA, it's our inhibitory neurotransmitter. Low levels of GABA equals anxiety. High levels of GABA are calming. And sometimes it might just be kind of ingrained in the person's genetics, right? That they have this GABA dysregulation. Sometimes we are doing things that can lower our GABA. Alcohol is a big one. Alcohol lowers GABA. So when you drink alcohol, you're lowering your GABA, and that is in turn why we see a lot of anxiety in alcohol use disorder. Psychodynamic is a lot of our Freud, those defense mechanisms, childhood conflicts, different things. Freud likes to blame the mother and parents for stuff. Are happening that kind of set the tone early on. Interpersonal kind of ties in. Anxiety is contagious. So if we have a mother who is anxious, she is then going to transmit her anxiety to her child. Behavioral theory, learned response. Sometimes it's called signal anxiety. If I were to walk in class and be like, put everything away, pins out, we're going to have a graded pop quiz. You would all of a sudden be extremely anxious. Social learning, we learn anxiety from those around us. Cognitive theory is our thoughts. If you have that negative thought, that just gets stuck in your head, and that then distorts your outlook. I've never been good at math. I'm just not good. I'm not good at math. I wasn't good at elementary school, middle school, high school. It doesn't matter. I just can't understand this. I will never be able to get dosage calc. I will never be able to do it. That would be a cognitive example. Culturally, sometimes it's a lot easier to complain of headaches and upset stomach and body aches than to actually complain of anxiety. And we see those somatic symptoms disorder, specifically or somatic complaints, in some of our cultures. We also see differences in kind of what panic attacks look like. Panic attacks could be, right, witchcraft, magic in some. Japan has a different view of social anxiety, right? Eye contact. That is when we always talk about. In America, we make a lot of eye contact. However, eye contact is offensive and can cause a social anxiety in Japan. So our nursing process, what are we going to have to think about and do? Patient-centered. And we're going to assess anxiety just like we do pain. On a scale of 0 to 10, how bad is your anxiety? What started it, right? Was there a trigger? What has helped in the past? What has been able to make it better now? What makes it worse? All of those different things. We have to look at culture and social because it's going to vary depending on our patient. We have scales that we can use. Suicide, self-harm are definitely good. Physical is good in that panic attack. We need to rule out heart attacks at times. Diagnoses will be linked to that patient. Oftentimes, like impaired coping, ineffective coping is a good nursing diagnosis. Outcome identification would depend on that specific patient. I want my patient to, I'm trying to think of a good one, to try 3 new coping skills today, right? Something simple, and then work through with the patient. Because it's hard. We don't want the patient to focus on the stressor. Exercise is great, like preventative, but I really want my patient to focus on like guided imagery, deep breathing, a bunch of the different things that help. So kind of helping the patient set the stage. So when it comes to implementing, it really is also going to be the level of anxiety. We can see mild to moderate on one side, severe and panic on the other, because both we're going to address differently. Mild to moderate anxiety, we could address it in the moment, right? I'm going to talk about problem solving. I'm going to talk about coping skills. I'm going to teach you some deep breathing exercise because you still can understand. Panic, fight or flight, you can't process information. So it's very much a safety of the patient, those around them. We're going to change how we are communicating with that patient, right? We're going to stay calm. We're going to lower our voice, firm, short, simple sentences. I love and hate the phrase provide opportunity for exercise. I don't want to be like, hey, let's go to the gym to my patient having a panic attack. However, the patient may want to walk, they may want to pace, they may want to move at that point, and we need to let them. Exercise is great and better preventative right? That 20, 30 minutes, take a walk every day is better to help prevent anxiety to it. Severe and panic, we may use medications, and we'll look at those in a second. We'd also often at that point use a benzo because it will help calm that patient, increase GABA in that moment. And we also want to look at that environment around the patient. If there's a lot going on, maybe remove the patient to a more calming environment until our anxiety has decreased. And once we get our patient from that severe or panic down to a mild moderate, that is when we can teach and go through coping skills and really start to assess. Severe panic, we're more there to support the patient. So again, promoting self-care. We want our patients to be eating, drinking, sleeping, right? Going to the bathroom, taking care of themselves, because as we promote that self-care, that in turn increases our mental state overall. So we have a bunch of different medications. SSRIs will go into a lot more detail next week when we get to depression. Antidepressants are often our first line, especially our SSRIs. Some tend to be more calming. Some can be a little bit more activating in the moment, so we have to be mindful with our patients. Benzodiazepines are the one we often jump to in our brain. They do decrease GABA. They're great for panic attacks because they work fast and they're going to work for everyone. However, they don't last long. So we're going to have to take more and more and more, and there's that risk of dependence and tolerance. So short-term onesies and twosies, claustrophobic patient needs a MRI. Great panic attack. Sedation, ataxia, cognitive impairments are huge. I don't want to give this to someone and then have them go give a public speech because they're going to look a little intoxicated. We definitely have to caution in the elderly with this medication because of the sedating effect. Benzos often, if it gets mixed with alcohol or other medications, can lead to more of those negative outcomes. Benzos can decrease respirations, but not normally on their own. It's when we are mixing benzos with alcohol, COPD, sleep apnea. Buspar is a non-benzodiazepine anxiolytic. There is no risk of dependency with Buspar. However, it takes a few weeks to work. So in that moment, we're going to need to be teaching coping skills, working with our patients, or providing a different medication. Side effects are a lot less than with our benzos, but Buspar, Buspirone, there are still a few side effects. Beta blockers like propranolol is a common one used for social phobias. Antihistamine, we often see Atarax or Vistaril, also known as hydroxyzine. That can help PRN. I've seen actually both propranolol and hydroxyzine. I've seen those all PRN for when it's needed in the moment, or even scheduled for some patients who have kind of a more long-term anxiety. And then anticonvulsants. One of the ones we often see now is gabapentin. It affects GABA. However, we have to be mindful gabapentin does have high potential for misuse, along with sedation for some of our patients. So we do just have to be mindful of what we are using. Advanced practice information, so cognitive therapy, that is that negative thoughts and helping change it to a positive thought. I'm not good at math. And we change that thought to, I'm not good at this yet, but with practice I'll get better. Modeling, we show behaviors, right? I model appropriate coping skills, so my children hopefully learn appropriate coping skills. Systemic desensitization, we talked about that with phobias. I'm going to slowly start showing you spiders and introducing you to spiders until one day you're calm. Right? Slow. Systemic desensitization, we're going to think slow. Flooding, I lock you in a room full of spiders and you have to very fastly get over it. I flood your system with what you're afraid of. Response prevention is very specific to OCD. Well, we as nurses are not going to stop the patient in the middle of their compulsion. Response prevention, we ask a patient to delay. Often their therapist in a nice controlled environment. If you're afraid of germs and touching a doorknob is very hard for you, we have this patient touch the doorknob and then we ask them to kind of sit for a few minutes. And we eventually keep increasing that amount of time. And the whole point is for the patient to learn hey, I did this. I didn't wash my hands 10 times right away. It still turned out okay, and get the brain to connect it. Thought stopping is just what it sounds like. This is a negative. We kind of do, hey, hand binds. This is a negative thought. I'm going to end it. And I'm just not going to think about it. We're just going to replace it with a positive. And then cognitive behavioral therapy combines cognitive therapy and behavioral therapy. That is it for stress crisis and anxiety. If y'all have any questions, please do not hesitate to reach out and let me know.